Hello everyone, I'm Wanqing Peng from China. It is truly a pleasure to be here today. On behalf of our research team, I will be sharing the core findings of our trial, Qihuang needle therapy for motor symptoms in Parkinson's disease. Here's what I will cover today. First, let's start with why we did this study. The core motor symptoms of Parkinson's disease, bradykinesia, rigidity, tremor, and posture instability, have a huge impact on patients' daily lives. Levodopa is still our cornerstone treatment, but as we all know, long-term use almost always brings complications. And importantly, none of our current treatment actually slow down the disease itself. So, there is a real need for safe, effective adjunctive therapy, something that can improve symptom control and maybe reduce the medication burden. This is where acupuncture comes in, and it's what leads us to explore Qihuang needle therapy. Maybe you want to ask, what exactly is Qihuang needle therapy? The Qihuang needle is an innovative acupuncture instrument developed by Professor Zheng Huchen, based on the classical theory from Neijing and combined with his own clinical experience. The needle featured a hollow body and an arc-shaped tip. This design makes it stiffer, yet cause less tissue trauma. In terms of technique, we employ the Hegu needling method, involving rapid deep insertion to elicit a strong dirty sensation, but without needle retention. Let me show you two short demonstrations from Professor Chen. This shows perpendicular needling at Feiyang BL58. This shows transverse needling at Baihui GV20. Each Qihuang needle therapy session used only 3 to 5 acupoints. For PD, Professor Chen alternated between 3 acupoint formulas. In his clinical practice, he observed promising results, and that's what inspired us to test this systematically. So we decided a rigorous trial to put this to the test. A single-center, randomized single-blind sham-control trial. We screened 205 patients and enrolled 140. All with idiopathic PD on stable medication, home year 1 to 4, and were randomly assigned in a 1:1 ratio. Both groups received 9 acupuncture sessions over 6 weeks, twice a week for the first 3 weeks, and once a week for the next 3. After treatment, we followed them up to week 10. The primary outcome was the change in the Unified Parkinson's Disease Rating Scale Part 3, scored from baseline to week 6. A total of 129 participants completed the full study, yielding the completion rate of 92.1%. Only 1 dropout in the treatment group and 10 dropped out in the sham group. The two groups were very well matched at baseline. The sham control design was critical. We used the same needle type, but inserted it shallowly at non-acupoint site, which located 1 to 3 centimeters from the true acupoint, and without any manipulation. The needle was withdrawn immediately. Post-intervention blinding assessment reviewed no difference between the two groups in participant patient guesses regarding their group assessment. More than half in both groups thought they had received real acupuncture. This confirms that our sham control successfully mimicked the treatment sensation and induced credible contextual effect. Now let's get to the result. All of these are based on intention to treat analysis. At week 6, the Qihuang needle group improved significantly more than the sham group. The difference were 8.45 points on the UPDRS3, highly significant statistically, and more importantly, this exceeds the minimal clinical important difference, meaning the improvement was truly perceptible to patients. By week 10, the gap even wider to 10.88 points. This strongly suggests that Qihuang needle therapy has a genuine and sustained therapeutic effect. Now let me show you a case video from this trial. This is a 72-year-old male patient with Hong-Yang stage 4. All assessments were conducted in the on-medication stage by a blinded rater, and his medication regimen stayed the same throughout the study. The video documents his walking change from baseline through 6 weeks of treatment. At baseline, you can see the classic shuffling gait. Turning required multiple steps to complete. And he was at high risk of falling. After 2 weeks of treatment, he could walk without help. Still small steps, but look at the turning, already smoother. By week 4, he's walking faster. Stride length had improved, and turning keeps improving. At week 6, his walking and turning are nearly fluid. As you can see, from high fall risk to confident continuous movement, his UPDRS3 score went from 69 all the way down to 26. These benefits, however, were not limited to motor function. Let us examine the data on the non-motor symptom and quality of life. On the non-motor symptom scale, the between group difference reached 20.93 points at week 10. On the 39-item Parkinson's disease questionnaire, a quality of life measure, the difference was 90.36 points. Both were highly significant. This data tells us that by improving both motor and non-motor symptoms, Qihuang needle therapy. It truly enhanced patients' overall quality of life. We also look at the subtype. There was a clear interaction. Patients with the posture instability and gait difficulty dominant subtype showed the greatest motor improvement, whereas the tremor dominant subtype showed the least improvement. This suggests that Qihuang needle therapy may be particularly suitable for patients with prominent gait and balance impairment, providing valuable clues from personalized treatment. Regarding safety, the overall incidence of adverse events was 13.6%. The vast majority were minor bleeding or small hematomas at needle insertion site, all of which were transient. No serious adverse events occurred, and no participants withdrew due to the adverse event. Overall, the therapy is safe and well tolerated. Now, two interesting questions came out of this study. First, how do we make sense of the improvement in the sham group? The sham group did improve at week 6. That improvement faded, that improvement faded by week 10. This is a classic pattern. It reflects contextual effect, a combination of placebo and the non-specific physiological response to needle insertion itself. What this means is that the true effect of Qihuang needle therapy is probably larger than what we measure. Over 8 to 10 points difference is likely a conservative estimate. Second, why did PIGD patients benefit so much and trauma-dominant patients so little? This makes sense when we think about the underlying circuit. Different motor subtypes involved different brain network. We propose that Qihuang needle therapy acts mainly on the basal ganglia thalamocortical circuit, which are exactly the circuits driving PIGD subtype. Tremor, on the other hand, relies more on the cerebral thalamocortical pathway, which may be less affected. Of course, this is a hypothesis, and it needs to be tested with neuroimaging studies. Our trial has some clear strengths, such as rigorous methodology, successful blinding, and subgroup analysis provides personalized treatment insight. But we also need to be honest about the limitations. First, it was a single-center study. We need multi-center data to confirm generalizability. And the follow-up was only 10 weeks. We cannot speak to long-term durability. The high dropout in the sham group might have slightly inflated our treatment effect. And the mechanistic idea I just shared are still hypotheses, requiring further experimental confirmation. So, in the future, we plan to conduct multi-center trial with extended follow-up. Maybe we could incorporate multimodal approaches such as neuroimaging and three-dimensional gait analysis to further elucidate the efficacy and mechanisms of Qihuang needle therapy. exploring how Qihuang needle therapies synergize with medication and rehabilitation, evaluating its potential to modify disease progression. Finally, let me summarize the key findings of this trial. Qihuang needle therapy significantly improved both motor and non-motor symptoms in PD. It enhanced quality of life. The benefits are sustained, and it has a good safety profile. It is particularly effective for patients with the postural instability and gait difficulty subtype. We believe it deserves a place as an effective adjunctive option in comprehensive PD management. I would like to thank all the patients and families who made this study possible, and express my gratitude to the research team for their dedicated work. This concludes my presentation. Thank you for your attention.